All right, hello everybody. We're going to be talking about the midterm review. This is probably going to be a couple videos because this is a pretty long review. We're going to be talking about a lot of different things, covering the midterm today. So first off, let's talk about just taking a test, and just some basic test taking strategies. Make sure you don't cram. This is what I tell people. You either know it or you don't, so don't try to cram in all of the information, because you're just not going to remember it and you're just going to confuse yourself. You want to make sure you eat well, sleep well, drink plenty of water. Always make sure to read the question and pick out keywords. That's really important. You want to avoid distractions. Don't second guess your answer. Don't change your answer. Anytime you change your answer, you're probably going to change it to the wrong one. Look for words like often, always, usually, never, and have a positive answer or a positive attitude. Because if you think you're going to pass, you're probably going to pass. And if you think you're going to fail, then you're probably going to fail. So just keep the positive attitude. So, culture and communication. So, why do we want to provide culturally competent care? Because it improves the quality of care, patient satisfaction, access to healthcare. It develops that rapport with patients, trust, and improves your communication. And your patient-centered communication, open-ended questions, avoiding interruptions, active listening, and shared decision-making, all important things. And encountering difficult patients. Everyone will have that at one point in their career. You want to identify any contributing factors, acknowledge their feelings, set your boundaries, and maintain a professional demeanor in your interactions. All right, so we're going to move into GI. So some different GI issues, some acute issues that you may encounter. Acute appendicitis, things to remember. Right lower quadrant pain, has an acute onset, fever, they may have decreased appetite. It's very common in people that are in like late teens, early 20s. More common usually in males. Diverticulitis, usually on the left side. A lot of times seen in women and older adults. Treatment, ciproflagyl is first line. Augmentin is also used. Pancreatitis can be acute or chronic. Usually it's from alcohol, but it can be from gallstones, trauma, elevated triglycerides, and the causes can differ depending on your demographic. Is it in women, men, older, younger? So you want to think about that. Gastroenteritis, usually viral, usually self-limiting. In children, the most common is rotavirus, causes a lot of diarrhea, and with that, vaccination is key. Fluids. You want to keep up on that to prevent dehydration. Brat diet, bananas, rice, applesauce, toast. Treatment. A lot of times they don't need antibiotics unless it's bacterial. Chronic GI issues. Your GERD, also known as reflux, very common. You're going to see that a lot. First line treatment, PPI, H2 blockers. You want to think about any red flag symptoms with GERD. And what causes GERD? You want to think, what is the cause of GERD? Peptic ulcer disease. It's less common. A lot of times caused by H. pylori. It's a longer treatment period. PPIs. And with your PPIs, you want to be concerned about osteopenia, low magnesium, B12 deficiency, chronic kidney disease, C. diff, dementia, especially with long-term use. Crohn's disease can be any part of the GI system. You might have weight loss, abdominal pain, oral ulcers. Goal in this disease, control your disease, prevent relapses. Treatment, steroids, immune agents, biologics. Celiac disease. It's an autoimmune disease, and mainstay is a gluten-free diet. So, lots of different signs, especially with the abdominal system. So McBurney's point, right lower quadrant tenderness, significant for appendicitis. Psoas sign, that's when you have the patient push up with the right leg against your hand, also appendicitis. Ropesick sign, pain on the right side while palpated on the left, appendicitis. Obturator sign, you flex the right thigh at the hip with your knee flexed and then you rotate internally, also for appendicitis. Cullen sign, it's periumbilical ecchymosis from hemorrhage, usually intra-abdominal. Grace-Turner sign, it's ecchymosis of flank and groin from hemorrhagic pancreatitis. Murphy sign, pain with inspiration with palpation, right upper quadrant, usually for cholecystitis. So different assessment findings in the GI system to think about. same things you learned back in basic nursing school. You always start inspection. You look at the shape. Are there any masses, hernias, colors, scars, all those types of things. You want to listen, auscultation, normal vowel sounds, low pitched, gurgling, 2 to 5 a minute. If it's absent, you might think they might have a paralytic ileus. If they're hyperactive or high pitched, they might have a small bowel obstruction. You're going to do palpation, light to deep palpation. Do they have guarding? Do they have rebound? Percussion, tympany over air-filled structures, and it's going to be dull over solid structures. So working up, abdominal pain, always, always, always history physical exam. That's going to be your most important thing when you're working up anything in the abdominal system. That includes rectal and pelvic exam. And in male patients, also genital exam is going to be very important because you always want to evaluate is this a testicular problem. Lab testing, urinalysis, pregnancy, CBC, CMP, those are going to be basic tests, and then additional tests depending on where the location of their pain is. Other diagnostic studies you may need to consider, plain x-rays, an upper or lower GI series, ultrasound, CAT scan, endoscopy, sigmoidoscopy, colonoscopy, again, depending on where their issue is. Do they need a barium swallow? Are they having some dysphagia? Liver function tests. So here are some basic liver function tests, normal values and changes. You can see bilirubin, urine bilirubin, albumin, alk phos, PT, ALT, and AST. You can see uncomplicated obstructive jaundice, hepatocellular jaundice, when things are increased, when they're unchanged. So when you have the ALT and the AST, when the ALT is greater than the AST, you want to think hepatitis. So you think L is for liver. If they're both elevated, but the AST is higher, you think consumed. So AST, alcohol, statin, Tylenol, those are generally the causes when AST is higher than ALT. And alkaline phosphatase is normally elevated in children, so it's not a cause of concern. Antibodies, so IgM, the M stands for acute infection, they're miserable. IgG is past infection, the G stands for gone. So ways to remember that. So differential diagnosis in abdominal pain, you can see here. You've got diffuse abdominal pain. It could be from a lot of different things. Pancreatitis, diabetic ketoacidosis, early appendicitis, gastroenteritis, intestinal obstruction, mesenteric ischemia, peritonitis, sickle cell crisis, peritonitis, and you can see right or left upper quadrant pain, then right upper quadrant pain, left upper quadrant pain, left lower quadrant pain, right lower quadrant pain. So you can see, and that will help kind of guide what test am I going to order first? What's the best thing here? So now we're going to talk about hepatitis C testing. So this is a chart that kind of helps explain the different types of outcomes when you are testing for hepatitis C. So if you order the HCV antibody test and it comes back non-reactive, then generally it means no further actions required. The patient does not have hepatitis C. If their antibody comes back as reactive, then you have to assume that they have a hepatitis C infection, but they need some additional testing because it could be a current infection, it could be a past infection that has resolved, or it could be a false positive. So you need to kind of test for the actual virus to see actually what's going on. If their antibody is reactive, and they also have the RNA detected, then they have a current infection and you need to refer them for treatment. If they have the antibody and it's reactive, but they do not have any RNA virus, then they do not have a current infection. So it's likely that they either is false positive or they have a past infection that was treated appropriately. Hepatitis B is, again, something that can be very difficult to kind of determine. And remember your IgG and your IgM, and you should know this for the test. So you can see the abbreviations here, your anti-HBC, your antibody to hepatitis B core antigen, your anti HBs, your antibody to hepatitis B surface antigen, your HBsAg, which is your hepatitis B surface antigen, and your immune globulin. So chronic infection, you can see you get positive, positive, negative. Your clinically resolved infection, negative, positive, positive. Clinically resolved infection, negative, positive, negative. Previously vaccinated, negative, negative, positive. And then sometimes you get negative, 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 meaning they've never even been exposed, never been vaccinated, and never obviously been infected. All right, so GI issues in children. Intussusception. So you want to think bowel telescoping on itself, a sausage-like mass. Volvulus, twisting bowel, ischemic. You'll see swirling on a CAT scan. Colic, persistent crying, generally in children less than 3 months old for over 4 hours a day. You want to make sure there's no red flag symptoms. Counsel of parents. There's nothing that's been clearly shown to cure colic. It's mostly parent education and reassurance. Esophageal atresia, it's a birth defect. There's different levels of that. An omphalocele, which is a birth defect, where the organs are outside the abdominal wall. Hirschsprung's disease, which is a disease of the large intestine, where it's missing the nerve cells and then they're unable to pass stool. Duodenal atresia, again another birth defect, and it's the most common cause of a bowel obstruction in children. And pyloric stenosis, forceful vomiting, weight loss, intense hunger, and it's because of an abnormal muscular valve in the stomach. All right, moving on to diabetes. So here you can see the differences in the clinical presentation in type 1 and type 2. It is similar, okay, with polydipsia, polyphagia, polyuria, okay. You can see fatigue, lethargy, drowsiness, similar. Confusion, stupor, unconsciousness, similar. Difference becomes type 1, you have weight loss, type 2, obesity. Type 1, fruity breath odor, okay, and also dehydration. Type 2, a lot of times you'll get infection, you get the skin tags and the acanthosis nigricans, so you want to remember that. Here's that chart that I used last time in regards to the treatment for type 2 diabetes, okay, and hyperglycemia in adults. I know this is very complicated. This is the most up-to-date chart in regards to the treatment for type 2 diabetes. Remember, number one is always going to be lifestyle modifications, okay? And it depends on where they are and how high their A1C is, and also what is their risk factors, where you start them. So, some common diabetes medications you can see here, and what they are. We've got metformin, some dose ranges, glucophage, glipizide. We've got our DPP4 inhibitors, Starlix, Actos, okay, and then some combination medications. I would know that, not every single one, but most common ones. Gestational diabetes. Screening at 24 weeks pregnant, okay, that's for everybody. Asymptomatic, even people with no history. Their diagnostic criteria for people with gestational diabetes is the same as people with regular type 2 diabetes. Management, diet, and exercise. You monitor their glucose levels. Insulin is first-line treatment. Oral therapy may be used, okay, but insulin still is the mainstay. Complications, hypoglycemia in infants, and macrosomia. Mothers have the same risks as with type 2 diabetes, which is the renal disease, cardiovascular, retinopathy, and hypertension. Diagnosis for diabetes: fasting glucose above 126, your 2-hour glucose with a glucose tolerance test above 200, random glucose above 200 with classic symptoms. And your goals of treatment: you want to reduce your complications, your A1C under 7, but remember, some patients need higher, and your first-line treatment, lifestyle management. All right, so we're going to keep the next slides on the next video.